speaker, Dr. Gaurav Sharma. He'll be presenting on confounding case scenarios in neuro-ophthalmology.
Thank you, sir. Good morning, everybody. I'll be speaking on confounding case scenarios in neuro-ophthalmology. The first case is one which made my neurologist friend very confused, and this was a 30-year-old patient who was having headaches, and the neurologist was had been referred by an eye surgeon as a case of papilledema, and even multiple fundus examination all showed that the patient was having papilledema, but since she didn't fit into the criteria of IIH and MRI was normal, the patient was referred to me, and when I examined, I looked at the fundus, and it looked like the disc margins are blurred, but you can see that this kind of a nodular protrusion over the disc was there, and also you could trace the vessels very clearly over the disc margin. So it was not a case of true disc edema, it was optic disc drusen. So optic disc drusen should be kept in mind, and with the possibility in patients with papilledema, you should not mention papilledema in such cases because the neurologist would then go for overall investigation, even invasive ones. So OCT also showed some hyperreflective bands suggestive of optic disc drusen. The second case was in fact a case series of patients who presented recently around 2 months back to me with almost similar clinical picture of unilateral disc edema with hemorrhages around the disc in patients who were both hypertensive and diabetic and with a similar kind of vision loss. And this patient, male patient, had 660 vision on right eye and 618 on left eye. The fundus examination you see in the right side, the hemorrhages confined to area around 2 disc diameters around the disc only. Left side it was looked like a picture of grade 3 hypertensive retinopathy. So was it papilledema, grade 4 hypertensive retinopathy? The blood pressure was not very high. The neuroimaging was also normal. The patient was lost to follow-up initially, and when he came back after a few weeks, he had optic atrophy and PL positive vision on the right side. The second patient was a female, again similar 6/36 vision, and the fundus examination, again intense hemorrhages over the left disc on the left side and some venous tortuosity, but the other eye was absolutely normal. Is it CRVO? But not a classical picture of CRVO. The hemorrhages are not that much extensive and confined around the disc only. And the third case, again this patient hemorrhages around the disc but sparing the temporal part of the disc, more on the nasal side. And the fourth case, again hemorrhages near the nasal side, sparing the temporal side. So all these 3 or 4 cases had similar clinical picture, were all hypertensive and diabetics. So what was the cause? Was it a severe NAION, or was the patient having some complication because of combined use of these newer anti-diabetic drugs and calcium channel blockers? Calcium channel blockers are known to cause it, this NAION, but these drugs were also common in these patients. We're still looking for what is the cause for these patients. Now, this case was a third case, was referred to as a simple case of optic neuritis from the field and looked like optic neuritis as a 30-year-old patient with RAPD and 5/60 vision. And you can see that there is a disc edema, but this area just around the disc on the nasal side of the disc attracted my attention, and we investigated. Look, it was found to be a choroiditis patch and investigated for tuberculosis and put on ATT and steroids. So this was a case of juxtapapillary choroiditis with neuritis. Now, this patient was presented to my resident with the history that she cannot see the stairs while walking downwards, and so my resident investigated for the visual fields and found there was an inferior altitudinal field defect and brought this patient to me as a case of NAION, possibly NAION. But she had omitted the dilated fundus examination, and you can see that this is a case of hemicentral retinal artery occlusion. This girl was found to have SLE as a cause for this vascular occlusion. The same resident, few weeks later, again had another patient, 33-year-old lady, with again similar complaint of inferior field loss, and this was the visual field. And this time she dilated the fundus and found that there was again a hemicentral retinal artery occlusion in this patient. So always do a dilated fundus examination before making a diagnosis of a neuro-ophthalmological disease. Now, sixth case was a patient referred to me by the neurologist. He had stroke and neurological deficits, and neuroimaging showed infarcts in the different areas of the brain, in the parietal lobe and the temporal lobe. But on examination, we found that he had a right homonymous hemianopia, and the dilated fundus examination again in this case was undertaken, and we could see these small dot hemorrhages in the mid-peripheral retina, suggesting a possibility of ocular ischemic syndrome. So we advised CT angiography, which showed that there was a non-opacified CCA and left ICA with formation of ECA by collateral. So we could get the cause for the stroke in this young patient. Now, this fifth case was a paramilitary personnel, and he was labeled as a malingerer. First, he was shifted from field duty to office duty because he said, I cannot do my work properly. He's always had a 6x6 vision. And even in office, he said, I cannot do so. He was referred to me as a possible case of malingerer. When I asked him, he said, I cannot localize the files which are present on one side. So when we did the visual fields, we found he had a bitemporal hemino. So he's certainly not a malingerer. And neuroimaging picked up this craniopharyngioma in this patient, and this is an intraoperative picture of this patient being operated, and both his sight and vision and life was saved by timely intervention. Now this case, I know slides are moving forward. This case was a patient came to me from a peripheral area, very far flung from my center, and he had vision loss affecting one eye, finger counting at 1 feet. Pupils were sluggishly reacting. There was anisocoria, and there was some mild proptosis and restriction of adduction and elevation. So we suspected possibility of a lesion near the orbital apex, and we admitted this patient in our ward. And since he was, he had planned a neuroimaging and orbital imaging, but since he was admitted with us, we decided to do the visual field of the other eye, and we found that this patient had a temporal field defect on the left side. And therefore, we changed our plan to neuroimaging to brain imaging, and we found that this patient had a pituitary macroadenoma with this figure of 8 kind of appearance and compression of the chiasm with intertumoral hemorrhage. So that's all. Thank you for your kind attention.
So thank you, Gaurav. That was an extensive presentation where you have taken into account all the presenting features. And neuro-ophthalmology as such is not only ophthalmologist, but you have to take into consideration other specialists, maybe a radiodiagnosis and a neurologist into the account. So